Welcome to the third video presentation of the elbow and forearm, and this one is going to cover the physical exam. Now you're going to be going through this in detail with Casey and Jean during lab, but I just wanted to do a quick overview. Of course, we are always going to start with inspection whenever we're looking at anyone coming into physical therapy. So as we watch them walk in, you might want to notice if their arm is actually in a sling or if they're wearing a brace. That's always good. You want to watch, how they move when they put their coat on and off, and maybe they're carrying an object or they're carrying it on the same side as their involvement or opposite side. If they have a child with them, are they holding their hand or not, carrying the child? Look at the types of functional activities that they can do. Specifically to posture, you might recall that in the frontal plane we can have a varus or valgus at the elbow, and normally we do have about 5 to 10 degrees of valgus in a man and about 10 to 15 degrees of valgus in a woman, and that's also referred to as the carrying angle. And probably, we think that it may have developed functionally so that when we were carrying something it didn't hit our legs as we were walking. That's always also the reason why we think the carrying angle is a little bit bigger in women, to accommodate for a little bit wider hips. It would be abnormal if we saw a carrying angle that was greater than that 15 degrees, and certainly it would be abnormal if it's much less than 5 degrees. It can actually deviate into varus and be called a cubitus varus, and it's also called a gun stock deformity. Now you have to remember that back when a lot of these terms were being developed, things like guns, especially shotguns like this, were probably a lot more common household item than they are maybe today. So people looked at this forearm deviation and said it looked like a gun, the stock of a gun. So that gun stock of deformity usually doesn't occur at birth. It's typically after some kind of injury to the elbow, like I've seen it often in fractures, like when children have elbow fractures and it just doesn't quite repair right. They end up with a varus deformity. We of course always want to be looking for edema, and edema can tell us, give us some clues. The pattern of the edema can give us some clues about the underlying pathology, and if the edema is very localized, then of course we would suspect whatever structure is right underneath it. And of course you know that we have a bursa around the olecranon to protect the olecranon and the skin from wear and tear against each other. So there is a bursa there, and that can get inflamed. That's a very characteristic appearance. We may see some other localized edema around the area if there's a trauma, for example. We don't usually see a lot of edema with epicondylitis at all. There's certainly tenderness and inflammation, but I know that's not the same as edema. If we saw generalized edema all around the elbow, then we would suspect something more within the joint capsule. Finally, when we're looking at inspection, we want to just look at the quality of the skin, note any scarring or discoloration, changes in color, maybe even little areas of muscle spasm that we might note. So as you're going through and doing your exam, of course you're going to do your bony palpations with soft tissue palpation. In addition to doing the different elbow flexors in the triceps, I am going to have you palpate the ulnar nerve. Remember, that's between the medial epicondyle and the olecranon process, and just want to be kind to your partner when you're palpating that. Don't zing them too much. You're going to palpate the wrist flexors and pronators together as a group at the medial epicondyle, and the wrist extensors as a group at the lateral epicondyle. And then finally, in the soft tissue palpation, you'll just be doing palpation of the brachial artery. Remember, we did this way back in the first semester when you were doing blood pressure, and you would note that most of the time it's going to be medial to the biceps tendon. The final element then of the physical exam will be the special tests. And we'll start with the varus stress test. And remember that terminology, it means you're trying to push the forearm into varus. Remember, varus, when you're starting from the vantage point of the elbow, that would mean the forearm is going medially. And so you can see here the person's hands are arranged so that they can stabilize on the medial aspect of the elbow joint, with the other hand distal, just a little bit proximal to the wrist actually, and the person with that hand would be trying to push the forearm medially. If there was movement or gapping or a lot of pain, that would be positive for damage to the lateral collateral ligament. The Varus valgus stress test is just the opposite. We're going to be looking to test the medial collateral ligament, or the ulnar collateral ligament in this case. And with that, we're going to have the elbow in extension, this time stabilizing on the lateral aspect, trying to push then the forearm laterally. And again, you may see pain, but generally what we're looking for is laxity or movement. And you definitely need to test these bilaterally, because you're going to see, even among your own peers in class, kind of a big difference in how much laxity people normally have. The next special test is called the Tinel sign. And you're going to see that Tinel means tapping over a nerve. So we're going to actually have a couple of Tinel sign tests that we do. This one is going to be the Tinel sign for the ulnar nerve at the elbow. And since you just palpated the ulnar nerve, you know where that is. And you're just going to tap right over the ulnar nerve. And it would be positive if it sent kind of shooting numb and tingly, zingy kind of feelings down the ulnar aspect of the forearm and even into the ulnar border of the hand. There is a little bit of connective tissue that stabilizes the ulnar nerve against kind of the back of the humerus there, and so that's called the cubital tunnel, and that can be, the nerve can become inflamed and kind of entrapped within there, and so this would be a test for some involvement of the ulnar nerve. And the last two tests are going to deal with the other pathologies we talked about with lateral and medial epicondylitis. So if we want to test and confirm a diagnosis of lateral epicondylitis, essentially what we would do is just create active contractile force on the wrist extensors. So we would just stabilize the forearm, have the person bring their wrist into extension, and then we would do a forceful isometric contraction. And we would ask them if there were any symptoms or any pain, and we would, if it was positive, that pain would be located at the lateral epicondyle at the attachment of the wrist extensors. And I don't have a picture, but for the Gulf elbow test for medial epicondylitis would be to place that wrist in flexion instead of an extension, and to forcefully resist the wrist flexors. So anytime we see a tendinitis of any kind, forceful contraction of the involved muscle is going to create pain. That's going to be positive because you're putting stress on that injured and inflamed tissue. So that's it for the quick overview of the physical exam. So this means that you're all ready now to meet with the lab assistants in lab and go through the exam, and then go ahead and go through the activities on the lab as well. The lab is posted on Blackboard. And remember to take your Kisner and Colby book. That's got great resources for you as far as exercises that you can do. But don't be afraid to be creative. Try to create your own exercises based on your knowledge. So have a great day, and I will look forward to seeing you next week. Thanks very much.